team from the University of Kansas Medical Center. We provide services at Cameron Regional Monday, Tuesday, Wednesday. So if you have any urological needs, we're here to help you. Every quarter, one of our residents picks a topic and gives a talk to the community. So today our resident is Dr. Valadon, and she's going to give you a nice talk on lower urinary tract symptoms in men. We like this to be sort of a discussion forum, so feel free to stop her at any point, raise your hand, yell out questions, whatever you need. We're here to help and educate the community and help you with your needs. We'll just wait for a few people to sit down. We'll get them some food and then we'll get started.
Everybody doing okay today? Everybody's good? Good. Well, thank you all for coming out. I'm excited to get to talk to you all today. Like Dr. Mears said, I'm just going to wait for a few more people to sit down and then I'll go ahead and get started, okay?
First time I came to this one,
Must have been a bad signal.
well, I flew, it's always on the moon.
What was the signal?
I think it was the ED. Well, maybe, I know what it was, kidney stone. But one trooper, Kathy was here and me, Katie was, and the rest of them were hospital people.
You wouldn't let her come today?
I wanted to do is you got the lady practice, they got no problem. I usually do it, but I can't keep up with it. Comes out with new songs every week. 5 or 6 or 10.
Yeah, this is my first time coming here, so, and I didn't drive.
Play one
This
for a
is
whole
my first
month.
time coming to this place, and I didn't drive, so I probably would have had to come too.
10 would be plenty to repeat.
Oh my.
Everybody want to sit with people going?
All right, thanks again, everybody, for coming out. So today we're talking about lower urinary tract symptoms in men, and that really is focusing on bladder symptoms, just to be a little more clear, okay? That's what the lower urinary tract means. So our objectives today is I'm going to talk about some common symptoms that men experience. We're going to go over a variety of those. We're also going to talk about what those really mean in terms of their definition. Then we're going to talk about some things that if you were to come into a urology clinic that we might do to work those up. So that way you can get a little bit of information about how we look at things from our perspective, but also what you could potentially expect. Then we're also going to talk about the differential, and what that is I picked some common diagnoses that we see in the clinic that are most common in the population, and kind of working through that. And we can talk about different ones, and if you guys have any questions, like Dr. Mears has said, at any point in time, please just stop me. I'm happy to answer. But I did want to make this a little bit of an interactive session, so I'm actually going to flip it to you for just a second. So knowing that we're talking about the bladder here, I wanted to know if you guys could potentially think of some symptoms that patients or men would come into clinic and be asking about. Do you guys have anything in particular that you could think of or that you are curious about in terms of symptoms? Or would you like an example?
Frequent urine.
Frequent urination is definitely a very popular one. Anybody else?
Unable to control it sometimes when maybe outside or wherever.
That's right, yep, incontinence, so leakage of urine is definitely one.
ED, I take finasteride and then, what's that? Flomax.
Yeah, yep,
Both together, but if I wake up about 4 or 5 times during the night.
that's right, nocturia. So nocturia is where we kind of go to urinate at night.
Are there some medicines that cause this?
Some medicines that cause people to have urinary symptoms. There are actually, and we can kind of get into that. I'm gonna table that for just a second. There's a slide that I have that I think it'll fit a little bit better, but I'll come back to that, okay? Any other symptoms that anybody can think about? If not, I'll go ahead and move on.
Yeah, you have to urinate, I mean, right now, but when you go and urinate, you're not a thimbleful.
Okay, so that actually is good, because that right there, you've hit on two symptoms that we see. So one is urgency, meaning that when you feel you have to go to the bathroom, you have to go right then, and there's no stopping it. The other one that you described is what I call hesitancy, which means when you go to the bathroom, you're waiting to go and you're just standing there waiting around, right? Yeah, waiting for things to start. So that's what I call hesitancy. So that was great. Thanks, guys. I appreciate it. Oh, one more.
Any correlations between Parkinson's and bladder urinary control, and have you got some experience or cross-training or anything, or will you be addressing something like that?
That's actually a really good question. I'm gonna come back to that one too later on down the road, but you're right. And Parkinson's is kind of one where we can see different urinary symptoms, and it's more of an individual level, but yes, there are ways that we can help with those symptoms that those patients experience, okay? Okay, so I'm gonna move on, and I'm just kinda gonna give you the host of symptoms that I thought of would be really good to kind of talk about for this. So urinary frequency, incontinence, urgency, nocturia, hesitancy, intermittency, double voiding, and incomplete emptying. So this is just kind of the list of things that I'm gonna walk through, and we're gonna talk about each symptom, okay? So we're gonna start with frequency. I know that you brought that up, so frequency is where we go too often, and it can really vary from person to person and what impacts that. So when somebody comes in and starts talking to me about that, I ask questions like, well, what do you drink? Do you drink a lot of water? Do you drink a lot of caffeine? Because sometimes our diet and what we drink can impact the amount of times that we go to the bathroom. The other thing that you hit it on was medication, okay? Especially some types of medication that we use to treat diabetes can cause the sugar, right, so glucose, to go into our bladder, and that's how the body gets rid of it with the medication. That one I see a lot of frequency urgency with, so that's always something that I look at too, is what medications are you on, and is there something that we could potentially work with your primary care provider to switch to maybe control those a little bit better. And again, bladder capacity, so that means how large your bladder is. Everybody's is a little bit different. So, and a question that I always ask, and he hinted on this one a little bit too, is when you do go to the bathroom, are you peeing a lot? Are you peeing a little bit? Or is it kind of a mix in between? So if you do come to the clinic asking that question, and that's something that you could expect us to ask, okay? So the next one that I wanted to talk about was incontinence, and that's leakage of urine. Okay, so there are questions that we would ask to try to characterize this a little bit better. Sometimes people have leakage of urine when they do physical effort, meaning when they pick things up, when they bend over, when they cough, sneeze, laugh. Sometimes people leak when they have the urge to urinate, meaning that they feel they have to go to the bathroom, but they just can't make it there in time. Other times they experience both of the ones that I've just described, okay? They have a combination of those symptoms. Unconscious means that you didn't even realize that you were leaking, but all of a sudden you're wet, okay? That's another one that we see. Continuous means that no matter what you do, sitting, standing, sleeping, you always have something leaking. And then nocturnal was one we talked about where you leak urine at night, so you might have to wear pads, briefs, depends, or something like that to help control that, okay? So that's what incontinence means. Then we're talking about urgency, and I kind of hit on that a little bit earlier, where you have the urge to go and you just have to go right then. You have to stop everything that you're doing, and that is your main focus. And again, this can occur with leakage, not all the time, Some patients might have some leakage and others not. And then I'll always ask, do you leak a little bit? Do you leak a lot? Or is this kind of a mixed, okay? Then we're gonna go into urinating at night. So waking up to urinate at night is something that it's kind of like the chicken or the egg to me. So I'll always ask, do you wake up because you have to pee? Or are you waking up because you're being woken up by something else? Maybe you have an animal that lives in the house, you heard a sound, whatever it is, and then your brain realizes you're awake, and then it tells you you have to pee. So again, it's like the chicken or the egg. So that can be really, really hard to try to identify, but it's a question that I commonly ask, okay? And then I'll ask questions like, well, do you drink a lot of fluids at night? And if so, what time do you stop drinking fluids? Do you drink all the way up until you go to bed? Is that something we could potentially change to help minimize the amount of times you're getting up at night? I talk about sleep disorders, seeing if anybody has like obstructive sleep apnea. Do they use a CPAP? Sometimes patients who have those things will wake up more at night. Some certain heart conditions, and then again, some medication side effects. Like if you were to take Lasix or water pills, that can cause you to wake up at night a little more frequently, okay? This one, I kind of combined a few of the symptoms. Hesitancy is what we talked about earlier, where you feel like you have to go, but you just can't go no matter how hard you try. Intermittency means that you're going, but all of a sudden your urine stream stops, and then it'll randomly start again, and it might stop again, so kind of a back and forth, okay? And then double voiding is where you empty your bladder twice. And what I really describe this is, or at least how I described it in clinic is, you know, you'll go to the bathroom, you'll walk out, and about 5 minutes later, you're like, darn, I have to go again. So that's what I call double voiding, where you walk out and very shortly after, you still have to go, okay? So that's something that I try to tease out as well. Incomplete emptying is also really important to us to know if you have, and that's where you go to the bathroom, but you feel like you just don't get all of that urine out, okay? You always feel as if there's something a little bit left over. And then I might also ask, well, do you have recurrent urinary tract infections? Because what will happen is if our bladders don't empty all the way, we always have a little bit of urine kind of hanging out in there, and that can certainly be a source or a setup for a urinary tract infection, okay? So that's something that I kind of, in addition, add on to there. Does anybody have any questions before we kind of move on to the workup about any of the symptoms that I've described, or what questions we might ask? Yeah.
Well, my dad had trouble with his prostate,
Mm-hmm.
and, so at 3 one morning, I had to take him down to Liberty,
Yep.
and it took a long time to get him killed, but he finally couldn't go at all, so they had to ream him out.
Okay, yeah. Yeah, definitely. So that is called, it sounds like BPH, or like an enlarged prostate. So I have a slide on that too. We'll definitely get to that. But yeah, some patients, if they have, you know, really large prostates, they can go to what we call acute urinary retention, which means all of a sudden they can't pee no matter how hard they try. And then they end up in the emergency department, and we usually get called to help out with that, meaning a catheter gets placed or whatever the case is. Okay. All right. Well, I'm gonna move on to the workup. So these are things that we use as tools as urologists to try to kind of help identify what's going on with the patient. So I wanted to talk about this because if you end up coming to a urology clinic, we might do some of these things, and now you might know a little bit more about why we do them and why it's important to us. Okay, so things I'm gonna talk about are a physical exam, avoiding diary, which means, you know, writing down when you pee, a cystoscopy, urodynamics, and some imaging, okay? So we're gonna start with a physical exam. Things that we do in clinic for most all of our patients is we do a urine test. So we have you pee in a cup and we check it to make sure you don't have an infection. Then we do a little bladder scan. So we'll have someone come in, they take a little ultrasound probe, they put it on your belly, and what the purpose of that is to see if you have any urine left in your bladder after you've peed, okay? Because we wanna know if there's anything left over. And then sometimes we'll do a prostate exam, kind of depending on the symptoms that you're explaining, especially in men, right, who are coming in with symptoms of frequency, urgency. We just wanna get an idea of how large the prostate is, and that's the test that we can do at clinic to try to focus on where we need to go next, okay? Avoiding diary is exactly kind of what I mentioned earlier. So it's where we would tell you to keep literally like a specific notepad, and I would want you to write down everything you do for 3 to 7 days. So every time you go to the bathroom, I'd want you to document that. I'd want you to document how much you peed each time, even if it's in the middle of the night. So usually we give something to measure that. okay? I want you to document when you drink fluids, what type of fluid it was, how much of that fluid you drank, okay? If you leak, if you're a patient who experiences leakage, I want you to write down every time you leak. And then kind of estimate, you know, was it enough to change the pad that you had? Was it enough to change the brief? And if you are using pads or briefs, how many of those are you using each day? This is all really important information to us because we can get an idea of how severe your symptoms are and also try to identify what might be going on and what's causing this, okay? Another part that we might ask about, and you might be a little bit surprised, is we are also asked about bowel habits because constipation can really impact your urinary symptoms. So we'll always ask, you know, do you have regular bowel movements? Is that something we also need to try to tee up and address? Because we like to get that under control first before diving into more of the urologic symptoms, okay? So I put this picture up here. This is a cystoscopy. So this is something that we do in clinic, or we can do it in the ER, but usually we just do it in clinic. And what it is a very tiny camera, and we put it through your urethra, which is the tube that you pee out of, and we take a look inside your bladder with the camera. Things that we can look at with the cystoscopy is we can look at the bladder lining. We can see if it's nice and healthy. We can also look to see if there are any stones in there. We need to deal with those. It gives us a really good look at the prostate to see if the prostate has started to come into the urethra, because the prostate does grow in men as they age. And if it starts coming into the urethra, you might get symptoms such as this gentleman described, where you have an enlarged prostate that's causing you not to be able to pee very well, all right? And we can also get a really good look at the urethra to see if there are any kind of narrowing, if there's any narrowing of the urethra at any point, or anything we would be concerned about. So we do cystoscopy all the time as urologists. It's a very helpful tool. We don't always recommend it for patients, especially when we're first starting to work people up. But we do get to a point, you know, if we're considering doing a surgical management where we'd want to do this. So if we recommend this at any point in time, that's why it's very helpful. Urodynamics is also something that we do in clinic, and our nurses are fantastic and they help us out a lot with this, which we appreciate. So what it is essentially, it allows us to see how well the urine flows out of your bladder. Does it flow slowly? Does it flow quickly? Does it seem to be like there's a blockage? We look at how well your bladder fills. You know, does your bladder fill only a small amount before you start getting those symptoms? Does it fill a large amount? Do you fill too much? Is your bladder too large? It tells us how well you empty, meaning does your bladder contract? Does it squeeze down the way we want it to? If does it not, you know? And then we also can see when the bladder contracts when we don't want it to. So a lot of times that's with that urgency, right? The bladder is contracting when we don't want it to, and we can see that. We also ask that you do some things that people probably find a little bit silly, but we ask them to cough or sneeze or try to, you know, add some pressure into the abdomen, because some people leak with those symptoms, and we want to see if we can reproduce that. We always do the ultrasound on the belly, which I talked about earlier, to see if you empty all the way. We do that with this test too, just to kind of see what that looks like at that point in time as well. So this is a helpful test. We don't actually put leads on your bladder here as in the image, but it gives us an idea of what your bladder is doing, and it's very helpful, okay? We're gonna talk about imaging, and we recommend different types of imaging for different types of things, okay? But some of the most common images that we would recommend for patients with these lower urinary tract symptoms, sometimes we do a CT scan, but really we like ultrasound. The ultrasound is helpful because it lets us see the size of the prostate. If we're worried about somebody having a large prostate and we might want to do surgery on them, we need to know how large it is to see what the appropriate treatment would be, okay, or which surgical intervention would you be the best candidate for. A retrograde urethrogram is essentially a fancy test where we put a small catheter into the tip of the urethra and they shoot some contrast down. And what that does is it lets us see if there's any narrowing in that tube at all. Okay, some people have what are called strictures, which means that tube has narrowed over time. And that is just an x-ray that lets us look at that, okay? CT scan, again, we don't typically recommend, but sometimes if patients have gotten CT scans for other reasons of their pelvis, we can look at that and calculate a prostate size. So it might save you from getting an ultrasound or something, okay? Does anybody have any questions about the workup or things that you might see or things that could potentially be recommended if you were to come to a urology clinic? Yeah.
Well, the prostate and sexual activity, does that, I mean, the frequency or anything have anything to do with this, the size of the prostate or the progression of the enlargement?
You mean the frequency? So that's actually a really good question. Patients that have really small prostates can still have these symptoms, and patients that have really large prostates can do just fine and not have any. It's really more of an individual basis, but yeah, if you do have a large prostate, most certainly I see a lot of patients who have frequency and urgency associated with that. Okay. Any other questions? Okay, we'll move on. So this is where I wanted to kind of get into some of the most common diagnoses that we see in clinic, okay? So this is actually gonna go right into what we were just talking about, a large prostate. So that's BPH, or benign prostatic hyperplasia is what we call it, but really it's BPH, it's a large prostate. So the prostate grows in men as they age, and there are two reasons that that happens. The stroma, which is just the prostate tissue, grows over time, okay? The other thing is that the prostate also has some smooth muscle in it, and that grows over time too. So really that's what we see is, bottom line, it just gets larger, okay? Some symptoms that we commonly see with patients who have an enlarged prostate are things like a weak urinary stream. It's weak, you know, it's not as good as when you were 18. I see that complaint quite often. Hesitancy or intermittent stream, we talked about that, where you have to go to the bathroom, but no matter how hard you push, you just won't come out. That intermittency where you stop and go, stop and go, stop and go. Waking up at night to pee is really common too with this. Urgency and frequency. I see that more in patients who have had, I feel like the enlargement of a prostate for a little bit longer of a time, because it starts to impact the bladder a little bit. But yes, urgency and frequency is one. And then not being able to empty your bladder all the way, just like we talked about, that retention, okay? The workup that you might see us do for this complaint specifically is we certainly would do a prostate exam in clinic. That gives us an idea of what size your prostate is just from our exam. And then sometimes if we're considering doing a surgery, we would do an ultrasound, like I mentioned earlier, to see if we can get the actual accurate size, because we're pretty good at what we do, but we're not an ultrasound machine. And then sometimes if patients have a CT scan, then we would look at that instead of trying to do that imaging, okay? Also, the cystoscopy in clinic, which is that camera I mentioned earlier, can look to see how much that prostate is coming into that tube where you pee out of. So if you come to clinic and you're having these symptoms and we're worried about a large prostate, this might be some of the things that we recommend. Doesn't mean we always recommend these things off the bat, but as we start to progress and we're really gearing towards more surgical interventions, this is what we would do. And I kind of have a picture here for you so you can look. So the picture that shows the normal is your normal prostate in comparison to that tube that's running through the middle is where you pee out of, okay? Yeah.
Well, they used to do the rectal exams, they say, I don't know if it's a certain age or what, you know, when they have a PSA.
Mm-hmm.
And my PSA's always been really low,
Mm-hmm.
but they used to do the rectal exam.
Mm-hmm.
And how, they do away with that, or is that what, whether they still use it or what?
So we still use it, that's the prostate exam. So we still use it if we are trying to work up whether or not somebody has a large prostate, but also if we're, you know, our patients are still in that age range where we recommend PSA screening. Anytime they come in with a PSA, we do a rectal exam, just to make sure we don't feel any nodules or things like that, yeah.
What is that age?
That age, right now, I believe they just changed the guidelines to 70. We're no longer recommending any screening after the age of 70, okay?
They're not, you don't recommend any screening after 70?
Nope. No PSA screening after the age of 70, but it's always a conversation that you have to have with your doctor, okay? Some patients are a little more concerned, some patients have different history,
I was
so
gonna say, not even if you have history of that in your family?
it just depends. It's all about kind of, we look at the whole picture. So the hard guideline is after 70, we wouldn't recommend PSA screening, but you know, if you have a family history, if someone is very concerned about it, but we also look at someone's health too to see what other medical problems they have, because at that age when you get prostate cancer, the majority of prostate cancers are something that are very slow growing. They aren't going to go outside the prostate and cause a lot of issues, and the treatment and workup of a prostate cancer at that time might do more harm than good. So it's always just a conversation that you have to have with your clinician to see if it's worth doing. Okay.
Looks like we're all gonna go home here real quick, that's up.
You what?
I said, looks like all of us are gonna go home here real quick if you take it.
No. So it's just a conversation worth having, for sure, okay? But this picture, the one on the other side of the screen, is showing just what an enlarged prostate looks like and what that kind of does to the urethra or the urinary tract, and you can see how it's compressing on it, and that might cause some of those symptoms we've been talking about, okay? A stricture is something that can happen in that peeing tube, and essentially what it is if your peeing tube is about this big normally, sometimes it starts to narrow down over time. So that's all that a stricture means, is that it's narrowing down, okay? There are many causes why this might happen. The majority of it is just unknown. We don't know. Sometimes people have prior trauma. You know, they've had prior surgeries before within the urinary tract. It can cause that. Certainly pelvic radiation is one that can do this, and then sexually transmitted infections, a history of that as well. Some symptoms you might see with this is similar, so weak urinary stream, intermittent stream. Sometimes patients get what I call spraying, which means if you put your thumb over the garden hose, right, and you start seeing two different streams, sometimes patients might see that as well. And then urinary retention, which is where your bladder just not emptying appropriately, okay? That fancy x-ray test I talked about earlier, the retrograde, that's what we usually do to work up a stricture to see kind of where it's located and how long it is. And sometimes we do a cystoscopy to try and visualize that in clinic as well. I have a picture for you too, and so you can see that kind of that peeing tube where that narrowed part is, that would be a stricture, okay? So it's not very common that we see that amongst a lot of the other symptoms that I'm talking about, but it is something to just kind of be aware of. So overactive bladder, so this is where you have like the urgency, okay? Most of the time you don't really know what causes this. Sometimes bladder ear inflammation can cause it, so urinary tract infections at the time can cause bladder urgency, so usually we always make sure that they're not, you know, someone doesn't have an infection at that point in time. Chronic bladder obstruction is like a large prostate, some reason that the bladder is not emptying the way that we want it to. Neurologic symptoms, stroke, okay, Parkinson's, multiple sclerosis. Sometimes we see a lot of urgency in that patient population, and then sometimes as men age, that just happens. So symptoms are the urgency where you have to pee right now, and sometimes people have leakage with that, and other times people don't. But that's an important question for us to try to figure out how we can gauge and what we can help with. I always ask about people's fluid intake, so caffeine is a really big offender to causing urgency. So I always ask, well, how much water do you drink? How much coffee do you drink? What else are you taking in during the day? And if they're a really big coffee consumer, I try and cut them down, and the same with, you know, sodas and things like that. Very big bladder irritating things. We do, you know, a prostate exam just to see if it's possibly due to a large prostate. This is where that voiding diary, where you keep a diary for 3 to 7 days of all your urinary symptoms, can be very helpful, because it can tell me, especially if you're having leakage, how much you're leaking throughout the day and how many pads and things we're going through. And then urodynamics, which is that testing we do in clinic to watch to see what your bladder does. Sometimes we recommend for this too. We don't recommend that off the bat, but if we've gone through several medications or things, we might look to doing that just to see if we can get some more information. And I just have a fun little picture here that shows like the normal bladder is filling okay. The overactive bladder, you can see that the bladder is not completely full, but it's starting to spasm even though it's not completely full, okay? So stress urinary incontinence, you know, most of the time when we see this in men, it's in men that have had a prostatectomy, which is a surgery where we take out the prostate for like a prostate cancer, okay? Also, you can have this after you have some surgeries. You can have this for BPH, which would be the enlarged prostate that you can do. You can see patients having this too. And so what stress urinary incontinence is where you leak when you do those physical maneuvers. Some people will have leakage when they bend over, when they pick things up, they cough, sneeze, laugh, okay? That's what that term means. Of course, we always ask about your history. Have you had any urologic procedures before? Have you had like exactly the prostatectomy or any surgeries for your enlarged prostate? Occasionally we'll do urodynamics, because those funny things I told you we asked you to do, the coughing, laughing, sneezing while we're testing, that's what we're looking for. And then sometimes we'll do a cystoscopy in clinic as well, okay? And this is just a picture showing that muscle that helps control your urine has kind of been weakened by some of those procedures. And a lot of times that will get better with time immediately after the procedure, but sometimes patients still have issues, and we're here to help with that if those exist, okay? And then the neurogenic bladder is kind of the last one that I wanted to talk about. So causes of this are patients that have had strokes, traumatic brain injuries, spinal cord injuries is certainly one. Some patients have what's called spina bifida, which is they're a congenital condition that they're born with, okay? Multiple sclerosis is another neurologic condition that patients can have, and then diabetes is actually a really big offender that can sometimes be avoided if your diabetes is under really good control. So I'll always ask when patients come in with a symptom, do you have type 2 diabetes or even type 1? What are your glucose? What was your most recent A1C? So those are all the levels that can give me an idea of how well controlled you are, because it's really important to keep that under control to try to prevent some type of damage from happening in other parts of the body. And so patients who have diabetes that's not controlled, some people might know they get like neuropathy of their hands and feet where they can't really tell things very well. That can happen to your bladder too. So that's what's happening with this, is that your bladder is just not being able to sense that as well, okay? Some symptoms that patients might have with this specifically is they're unable to tell when their bladder is full. They can't empty their bladder all the way. That's because it's not contracting as well as it used to. Overflow incontinence is something that we haven't really talked about, but it's specific to this, where the bladder gets so full and you can't tell that you have to go to the bathroom, but your bladder knows, so it will leak, okay? So you were leaking, but you didn't even know that you were about to leak, and so that happens. And then recurrent urinary tract infections can happen, as we talked about a little bit earlier, in terms of always having that low level of urine kind of in the bladder that sets up for infections, okay? I always ask about, surgical history and GI history, just to kind of see what's going on there. And then post-void residual is really, really helpful for this. And that's that ultrasound that we do in the clinic to check to see if you have emptied your bladder all the way. Because if you haven't emptied your bladder all the way, this is something that starts to kind of creep up on our concept of what might be going on, okay? So basically, lower urinary tract symptoms or bladder symptoms have a wide range of presentations, right? You can see that kind of from what we've talked about. Someone might come in with frequency, someone might come in with urgency, someone might not be able to empty the bladder completely. But I'm sure that you notice on a lot of these slides, the symptoms overlap with one another. So it's really kind of hard, and that's why we ask so many detailed questions, and sometimes why we want to do this workup. And we want to try and figure out exactly what's going on with the patient to see how we can help them best, okay? Because like I said, a lot of these symptoms overlap. But there are certainly ways that we can help manage these symptoms regardless of which kind of, column they're falling into as to why they're caused. We're happy to do that. We're here to help. So any other questions at this time? Yeah.
I used to go down, I was working in Johnson County, and I'd get about to Lamar from here, and I felt all of a sudden like I had to go.
Mm-hmm.
And so I'd find the gas station off Lamar. Well, then one day I just decided not to, I just restrained, and it just went away. That urgency just went away, and I made it all the way out to Gardner.
Yeah.
So I mean, what's happening there with that feeling of real urgent, but then really, just by waiting, I can put it off.
Yeah, no, that's actually a good question. Sometimes patients' bladders will do what we call as a spasm. So where it almost contracts and it makes you feel like you have that urgency where you need to go. But if you just wait long enough, the bladder will kind of relax on its own. So you're just working through that spasm, okay? Sometimes that works for patients. Other patients will get into the situation where when they get that urgency, they'll leak. Okay, if they don't get to the bathroom in time, they'll do that. So just a little bit different on each individual person. Anybody else? Yeah.
I'll go back to my original question.
Yeah.
Probably a little too specialized here, but personal frustration
Mm-hmm.
without any real physical examination. Primary care doctor, specialty doctor versus neurological Parkinson's doctor.
Mm-hmm.
When you bring up a situation, maybe my personal frustration, but each of them takes them about 1/10 of a second to point the blame to the other one.
Okay.
How do you break that cycle, and what might your clinic do differently or something compared to unhappy experiences that I've already been through?
Yeah, no, I completely understand. So it sounds like, you know, you're seeing a primary care provider and a neurologist, is that
And a-
correct?
And a primary a specialist, not just the primary care doctor. When
Okay.
you get referred off to I assume you would fall under the category of a specialist.
Correct, yes. We are
Okay.
considered like the bladder specialist. So if
Okay.
you're not seeing one of those, but you're having,
Oh, I've, all three.
you've seen all three, and they're all
Yes.
kind of pointing the blame at one
And
another?
I'm just asking a non-specific, non-focused question on you personally.
Yeah,
But can changing a specialist provider remotely try to break that cycle of it's always their fault?
it's a hard question because I can't speak for other providers
I know.
and I don't know the specifics, but I would say, and this kind of goes for a lot of medical conditions in general. If you're seeing a provider and you feel frustrated as if somebody, isn't listening, or if you feel like you're kind of getting the runaround, for lack of better terms, I always recommend just getting a second opinion. So if it's the specialty provider you're frustrated with, get a second opinion. If it's the primary care, it's not gonna do any harm, right? You can only get more information, and you might learn something that you didn't before, and sometimes having a fresh set of eyes is always helpful, because you may be going to a provider that's known you for 40 years, right? 20 years, whatever, how long it's been, but sometimes getting fresh perspective can be like, oh, well, I didn't think of that, but this is why I didn't think of that, because I'm so focused on XYZ, because I've been seeing you for XYZ for so long, I didn't think about A, right?
And what's your experience with the whole bird's nest of Medicare regulations of being able to have coverage at 2 locations for the same symptom under the Medicare umbrella that most of us probably have to deal with?
Yeah, that's actually a good question, and
Yeah, it is.
and I don't know the specifics of the Medicare policies enough to be able to answer that for you. Do they limit the number of specialists you can see per symptom?
I haven't yet got caught up in it. It's
Okay.
a perpetual thought, because every time you have to have a pharmaceutical intervention
Yeah,
or a physical intervention in the medical world, if Medicare isn't the first thing that comes to your mind, you may be a little bit inexperienced in the process.
yeah, no, it's definitely, something that I don't have too much experience with, and honestly, it's just kind of a wheel that continues to turn that we don't see too much of from the physician side. But I would say that, if you have to have a referral placed, you can always have a second referral placed if it comes from the PCP, if that's like the limiting step, right?
Okay.
To try to inhibit that. I don't see why you couldn't potentially see another provider.
Well, Medicare doesn't require a referral.
Okay,
So
Yeah.
if you wanna see any
Yeah.
provider, you just have to ask for an appointment.
You can call directly to our office and we'll be happy to schedule. We don't require a referral for our office, so if you wanted to see, or you know anyone that wants to see our urologist, please just call the West Side Clinic and we'll get you in to see one of them.
Okay, I was just gonna ask, are you Medicare or you're the Cameron?
We're
Facility.
in Cameron at the West Side Clinic in the same parking lot as Cameron Hospital.
Okay. And then I'll try to stop with this.
you're fine.
Are you gonna get into pharmaceutical intervention suggestions and theories in this, or?
No, I didn't go into that because they're so specific to the patient and what symptoms that they're having and what I think, like what we think the cause is, and there are a lot of options for that. So I didn't go into that because I thought it would be a little too much of information overload. But that's certainly, if you have any questions and you think that there might be a medication that we can help you with, just come. We're happy to see you and help out.
What about the long-term use of medications that have been prescribed for enlarged prostate for like 20 years? What's the end goal, or is there one?
There really isn't one. So as long as you're being managed well with those medications, then you kind of hit the stopping point. It becomes to the point, where you've been on these medications for 20 years and now all of a sudden they're not working as well for you. that's when we might make some adjustments, or we might consider some type of surgical intervention. But, yeah, we have patients who are on like Flomax, finasteride, things like that for years, and as long as they're managed appropriately and they're doing well, we're okay with that.
Do you have surgeries?
Surgeries to help with, for enlarged prostate specifically? Yeah, we do. We have several options, and that's where it gets important in terms of trying to find out how large the prostate is, because that would vary what we offer, okay?
My dad had it, they trimmed too much off the second time, he never could hold his urine, he was quite disappointed in that.
Yeah.
That's mild.
Yeah, I understand. That's kinda why I hit in here, you know, incontinence or leakage is something that you can see certainly after having one of those procedures, but, yeah. Okay, well, thank you guys so much for coming out. I appreciate it. Hopefully, everyone learned something a little bit, but, it was nice to meet all of you.
Thank you.